Uh, Hello, good afternoon, and welcome to this event where hopefully we will be able to answer some questions around the COVID vaccination programme and how it affects people who are pregnant and any fertility issues. Can we have the next slide, please? So we've got a number of people who are just going to run through a fairly short presentation. So my name's Tim Davies. I'm a public health consultant. My day job involves overseeing and supporting vaccination programmes, and that's kind of developed into a role in the COVID programme within the Midlands. It's quite interesting. Vaccination is normally a very important but rather low-key service in the NHS, whereas currently now clearly vaccination has become the #1 priority for the NHS regionally and nationally. I'm then joined by 3 colleagues from Birmingham Women's and Children's Hospital, Dr. Justin Chu, Rachel Carter and Tracy Johnston, who will run through some of the detail and the specifics around the vaccination programme and pregnancy. Just to say, today's webinar is being recorded and will be available afterwards. And I think the plan is if you have questions, if you want to jot those down into the chat, somebody will collate those, and we'll try and answer as many of those as we can after the presentation in the event. And any of those that we don't have time to do, we'll provide a written Q&A in response to those questions afterwards. Great. We just want to move on to the next slide, please, Laura. So just a couple of slides just around some background stuff around COVID generally. So as you know, we've been living with this for well over a year now. Yesterday was the anniversary of the first lockdown, as you all have been aware. Something in excess of 4 million cases in the UK and 126,000 deaths, and a huge amount of pressure on the NHS, both in terms of just occupied bed days, but particularly patients in critical care beds, and the length of time some people have been in critical care has put the services under a huge amount of pressure. And sadly, as we know, a significant number of health and social care staff have died as a result of the COVID pandemic. Next slide, please. So the vaccination programme, which is a very significant part of the way out of all of this, started in December, firstly with the Pfizer-BioNTech vaccine, and then followed pretty quickly after that with the Oxford-AstraZeneca vaccine. They're both now widely being used across the world, having been approved initially by the MHRA for use in the UK, but also by the European Medicines Agency and the WHO, who are not a regulatory body, but have certainly recommended its widespread use, or the widespread use of both vaccines. The trials showed that both vaccines provided a very good level of protection, and what's interesting is the real world experience, as more and more people have been given the vaccine, have added to that, and actually the evidence from the vaccines is still very good, that they are both safe and effective across a range of populations, so and particularly across ages, which is a really important and really useful position. And in the Midlands, this clearly changes on a daily basis, but we've now immunised in excess of 5 million people with their first dose, which is really excellent progress. So that's all from me. So I'd just like to hand over now to Dr. Justin Chu from the Women's and Children's. Thanks, Justin.
Thanks, Tim. I'm blown away by the number of attendees so far. So we've got 525 attendees. The computer's telling me, and I think that this is a real source of interest for lots of people around the Midlands who are thinking about the vaccine and what data there is out there. And specifically, as an IVF consultant here at the Birmingham Women's Hospital, I've been approached by lots of members of staff actually around the hospital whether that be midwives or nurses, domestics, secretaries, anyone really that wants to know whether there is an impact on the vaccine on fertility. And so if we can just change to the next slide, please. So you may well be aware that there was quite a lot of rumours. There were quite a lot of rumours going around around the back end of 2020 and the start of 2021 with the vaccines. And I think we need to have an understanding of where the rumours actually came from. Why were there rumours that the COVID vaccine was going to cause problems and harm for fertility in the future? So just to try and understand that, the reason why this came about was because there was a German doctor and a scientist that had a theory, and they wrote to Pfizer suggesting that a spike protein that's in the vaccine for COVID is similar to a spike protein that's found in human placental tissue. And that spike protein in the human placental tissue is syncytin-1. So I think that's a really important thing that you try and understand. This wasn't a peer-reviewed paper. It wasn't research that was done. It was a hypothesis by a couple of German professionals who were doing their own due diligence, to be fair, in terms of thinking outside the box. All right. Now, since then, what has happened is that learned societies such as our own Royal College of Obs and Gynae, along with the American College of Obstetrics and Gynaecology, the European Society of Human Reproduction and Embryology, our own British Fertility Society, and the American Society of Reproductive Medicine have all released a joint statement. And that is very, very clearly that there is no fertility loss with the COVID vaccine. That's not been seen in animal studies, and we've had all of those human trials before the vaccine was rolled out, as well as the millions of women around the world that have been vaccinated thus far. And actually, when the scientists went back to look at the spike proteins in the vaccine and in syncytin-1 placenta, they're actually really different. And because our immune systems are so clever, they're able to tell the difference very, very clearly. All right, so just move on to the next slide, please. So on the 8th of February, the British Fertility Society actually released a really, really useful statement. It's on a PDF document if you want to read it for yourself. Just Google BFS, British Fertility Society, and COVID-19 vaccine. And it's very clear, their guidance. People of reproductive age should have their COVID-19 vaccine if they're invited. And just to back up what I said on the previous slide, there is no evidence or theoretical reasoning that the COVID-19 vaccine affects fertility for women or men. And actually, you can have your vaccine if offered during fertility treatment, whether that is giving medicines to help you release an egg from your ovaries or actually formal IVF treatment. We move on to the next slide. And actually, fertility treatment can be started immediately after vaccination. Now, obviously, some women might opt to have their second dose of the COVID vaccine before embarking on fertility treatment, or if they've got some pain at the injection site, they might defer it by a few days. But the British Fertility Society are very clear on their guidance. Treatment can be started immediately after vaccination. And I'm not going to go into this in lots of detail because I've got two people here who are going to give you lots of information about this. At the moment, we're saying that if you're pregnant and you're at risk, then the immunisation committee are advising to have the vaccine if you're at risk. Okay. And the very last thing, I'm getting this through our Tommy's recurrent miscarriage clinic as well. The vaccine has not been linked to miscarriage or recurrent miscarriage. So again, if there's a history of recurrent miscarriage, you don't need to worry about that COVID vaccine. Just go and have it if you have been invited to. I think that's me done. So I'm going to hand over now to Dr. Johnston.
Thanks, Justin. So I'm Tracy Johnson. I'm a consultant in maternal and fetal medicine here at the Women's Hospital. Can I have the next slide, please? When we look at what happens with COVID-19 in pregnancy, the Royal College of Obstetricians and Gynaecologists did a survey, and they were able to do this because in the UK, very quickly we moved to a process of testing all hospital admissions for COVID-19. And of course, all pregnant women are admitted at some point during their pregnancy, usually around the time of labour and birth, but often beforehand as well. So as far as the pregnant population in the UK is concerned, we've just about had universal screening. And that showed that the incidence of COVID-19 in pregnancy was around 3.1 per 1,000 pregnant women. And that was split into a third of cases being completely asymptomatic and 2/3 that were actually symptomatic at the time of testing. And what they found with the asymptomatic group is that when we looked at the characteristics of the women that were found to be COVID positive during pregnancy and were asymptomatic, there was an overrepresentation of women from the Black, Asian and minority ethnic communities, and also women with gestational diabetes. What was really interesting, however, was within that population that were asymptomatic, they ended up with a 40% caesarean section rate, which is much higher than the background caesarean section rate, and a 9% neonatal unit admission rate, and much of that was not because the baby was sick with COVID, but because of prematurity. Like I said, 2/3 were symptomatic, and again, looking at the patient characteristics, there was an overrepresentation of women that were either overweight or obese. Again, the Black, Asian and minority ethnic community were overrepresented, and women with pre-existing medical disorders like hypertension were also overrepresented. And in that group, so women that were symptomatic of COVID during pregnancy, there was a 9% admission to intensive care, there was a 1% mortality rate, and there was an 18% preterm rate, and 14% of that was iatrogenic. So they were delivered early. A decision was made to deliver them early because of usually the COVID infection that they had, rather than spontaneous preterm birth. Also looking at ICNARC data, and that's data from the Intensive Care Society, their audit data, during the first wave this time last year, of the admissions to intensive care, about 9% of the admissions were pregnant, and they had a mortality rate of 13.2%. So if you were pregnant and ended up in intensive care, you had a 13.2% risk of dying. In the second wave, there were more pregnant women admitted to intensive care. The rate was 13.5% of all intensive care admissions were pregnant in the second wave, but the mortality rate had come down substantially to 5.1%. And that was because we've got better at treating COVID. We understand it better, and we've now got effective therapies like dexamethasone and so on. What we also know is if you get COVID-19 in pregnancy, it's worse the later in pregnancy you are, and we also know that the risk to the baby is minimal. Can I have the next slide, please? So who should have the COVID vaccine? Well, there is very good guidance that is out there, and the current guidance is that all pregnant health and social care workers should have the vaccine. All pregnant women who are in the clinically extremely vulnerable group should have it, and more recently, as things have moved on, pregnant women who are clinically vulnerable. So they're groups 4 and 6. When you look at the 9 groups for COVID vaccine, they're groups 4 and 6. There's also a little bit of a get out of jail card that clinicians can use. And if the doctor, whether it's the GP or whether it's the obstetrician, feels that the woman is vulnerable to serious disease for other reasons, so you may have a Black woman who is 42, who has got a BMI of 40, who is hypertensive and diabetic, you might think actually, or gestational diabetes, that wouldn't fall into group 4 or 6 on its own, but when you put all these risk factors together, that woman's very high risk. So you've got that little get out of jail clause there. And at the moment, JBCI, and if you want to find any of this, you just Google JBCI Green Book and go to chapter, I think it's 14A, which is all about pregnancy. They're under consideration at the moment is whether they should say that in the context of the age-based rollout, should we say if you are pregnant and you get a call for vaccine based purely on your age and you're otherwise fit and well, that you should have the vaccine. We don't know the answer to that yet, because at the moment you should only be having a vaccine if you're pregnant if you are called. And most people, there are very few pregnant women over the age of 50, although there are some, and that is a one-to-one conversation. So if they're otherwise fit and well, then JVCI is considering whether pregnancy should be included in the age-based rollout. Now, when we look at vaccines, we know that you get significant protection with 1 dose and better protection with 2 doses. In the UK, we're only using the Pfizer and the AstraZeneca vaccines, and they do not have virus in them. There are some vaccines in other parts of the world that do have an activated virus. There are none of the vaccines in the UK that do. They do not integrate into your body or into your DNA, and they do not replicate. So there is no risk from that. There's about a 3 per 1,000 side effect rate, which is usually mild, some fatigue, sore arm, headache and fevers, and none of these side effects have been shown to affect pregnancy. And some people had questions before about, well, if I get a really high temperature, which I got after my flu vaccine, does that increase my risk of premature labour? And no, it doesn't seem to. We know they work. And the most important thing is we know if you've had the vaccine, there is a significant reduction in hospitalisation and death. Next slide, please. Some of the questions that come up, women are worried about their unborn baby, and these are some of the questions that people have asked. mRNA vaccines are not live. They can't infect the mother, they can't infect the baby. The mRNA, which is the Pfizer vaccine, is very rapidly broken down in the body, so it can't become part of you or your baby's DNA. There is no evidence from animal studies that there are any concerns at all, but we need to acknowledge that at the moment there is no published randomised controlled data, there are no formal trials that have been published relating to the vaccine use in pregnancy. Viral vectors, and AstraZeneca is a viral vector vaccine, are non-replicating viral vectors. They don't multiply in the body, so it doesn't spread and they are destroyed really quite quickly. Animal studies indicate that the viral vector does not reach the fetus. They don't suggest any issues of concern, but again, there's no published data in humans, and we'll come on to that a little bit later. The pregnant human trials and studies are in progress. There's one already recruiting in the States, and there's one, a multi-centre in multiple countries about to start recruiting in May, and the UK is taking part in that one. So that data will come. I'm now going to hand over to Rachel.
Hello, I'm Rachel Carter. I'm the head of midwifery at Birmingham Women's and Children's Hospital. So in the RCOG survey, what we found, or what was found and reported, were there were actually 3 groups of women when thinking about the vaccine. There are the women who want to have the vaccine to protect themselves, their baby, their family and the vulnerable population as they're continuing to give care. And there are women who don't want the vaccine because they're worried it may actually harm their baby, or cautiously are a little bit hesitant and waiting for more information on safety. And there are also those who aren't sure, but they want to discuss it. And they want to discuss it with either their midwife, their obstetrician or the GP. What the survey showed us is more so they want to discuss it with their midwife. So they want to discuss it with somebody with whom they have that relationship, that contact, who they trust and who they tell their other concerns to as well. So we all need to be able to have this conversation, and we need to be able to be supported. And there are literature and there are documents out there that can help us. And most helpfully, the RCOG website, there is the information leaflet for women, for healthcare professionals, and also the decision aid. And we need to make sure that when we have these discussions, we're not making an informed decision for the woman, and she's not making it alone, but we absolutely must do it with women. Next slide, please. So thinking about the options and the offer, all these groups that you see across the top are professional bodies, our societies and information services. What they're saying is that there are 2 options. One is get the vaccine, and the other one is you could wait for more information. But if you're not a healthcare or social worker and you don't have that condition, then at the moment you're not even getting that choice. So we're in a really privileged position in the healthcare service and in those groups where we're actually being offered the vaccine. Hence, there's a real conversation that needs to be had about why you wouldn't have it. So risk is important, and the risk information is changing constantly, as it does throughout pregnancy anyway. And the latest information that has come out, as Tracy has said, shows that there are an increased number of people that it's being offered to now anyway, as we're seeing the groups 4 and 6. So the risk-based discussion and the information giving is what is the most important part to help women decide. Next slide, please. So thinking about the benefits. In summary, COVID, we know, carries a significant risk of morbidity and mortality. We know that the risks in pregnancy for both mother and baby, as we've already discussed, can be increased when there are infections, but COVID, we know, can cause more poor outcomes if you do contract COVID during pregnancy. We know that vaccination is effective in preventing COVID infection, and we know that they do not contain live virus. Vaccines do not contain any additional ingredients that are harmful to pregnant women or their babies. And we also know that you cannot get COVID from the vaccine. Next slide, please. So thinking about the risks, COVID vaccines haven't yet been tested specifically in pregnant women, but there are 2 studies in progress. And there are also studies available that are looking at what happens when pregnant women do, that we'll come on to shortly. Testing on large population numbers has been stringent and it is in line with safety standards. And what we know so far is there is no perceivable harm. And certain if it works as well in pregnancy is an important question, because we know that immunogenicity may be different during pregnancy, but we do know that it works. What's unknown, however, is if there are unique downsides regarding side effects, miscarriage, fetal development. And this is the question that people raise. But as Justin has said, there is information now that gives the answer to that, and all the societies that have put their names behind it and the very strong statements that are being put out there give us that assurance that the information that is coming forward tells us actually there are no safety harm or concerns that have been identified. Next slide, please. So as Tracy's mentioned, we know that the Black, Asian and minority ethnic population are more impacted by COVID, with 14% of that population of heritage, but 56% of them are with COVID, 14% of the pregnant population are Black, Asian or minority ethnic, but 56% of them have COVID with that heritage, which is significant. The evidence suggests that there is more vaccine hesitancy in Black, Asian and minority ethnic groups, but it's really important we don't label people as being anti-vaccine. These are the groups of people who are more hesitant and really who we need to have the deeper conversations with to give the choice and the information to help to make that choice. There's language barriers are also an issue, but again, if you go onto the websites now, the information literature is now being made available in multiple languages. So Department of Health have got information literature about the COVID vaccine available in multiple languages, and those that have got electronic systems, as do we're making that available to our healthcare practitioners, but also to women. So it's all about shared decision making through discussion, through information, and absolutely avoiding coercion. Next slide, please.
So we're just swapping back again. Data is really, really important, and women want the data and the reassurance to tell you that the COVID vaccine is safe in pregnancy. And as I say, the trials have excluded pregnant women to date, but these trials are starting now, but it'll be a little while before we get it. There are, however, different mechanisms, and data collection is really, really important, because the more data we collect, the more information we can give to women and families that are concerned about things, and rightly so. So there's a UCOS, UK TICS study, which is a study that during February and March, UCOS want all pregnant women that have received a vaccine in pregnancy to be notified to them, so they can then follow up. And anybody that works in maternity services is aware of the UK obstetric surveillance system, where they pick specific conditions. There is a well-established notification system in every maternity unit in the country where returns are put in, and they're very effective at getting population-wide data. So that's already in progress at the minute. There is also MHRA reporting through the yellow card system to make sure that information goes back about women that receive vaccine in pregnancy. And then the other thing that is really important is we've got a wealth of data within the UK. And there is also a wealth of data in America, and over 40,000 women, I think it's standing at now, have received the COVID vaccine in pregnancy in the USA. And there have been no concerns raised out of that large population of pregnant women that have received the vaccine. But the really important thing is that the FDA and the MHRA have got a formal data sharing process. They talk to each other, they share the data, they pool the data, and with that there have been no concerns. The other thing that we're trying to do in the UK is to try and get an electronic patient record solution to this, so that there is a mandatory field in pregnancy electronic records to say, has this woman had a COVID vaccine in pregnancy or not, so the data can be pulled out that way. They've managed to solve it with one of the EPRs, which is used fairly extensively in London, but not outside of London, but they are looking at trying to extend that to all EPR mechanisms that are there. Next slide, please. Women also ask about vaccination whilst they're breastfeeding and can be very concerned about taking a vaccine when they're pregnant. And what we know so far is that COVID vaccines are not thought to be a risk to the breastfeeding woman or the baby. And we know that the benefits of breastfeeding are very clear and are there. And any risk of the vaccine are far outweighed by the benefits of breastfeeding. So if otherwise eligible, so if a woman has been called to have a vaccine because she falls into one of the at-risk groups, she should be offered the vaccine. The developmental and health benefits of breastfeeding obviously need to be taking this into consideration when you're having that conversation. Now, because of all of this, the JCVI, who advises on who should have a vaccine and who shouldn't for the UK, they have recommended that the vaccine can be received whilst breastfeeding. And breastfeeding women should be informed that there are no data on the safety of COVID vaccines in breastfeeding or in the breastfed infant, but all this is in line with the recommendations in the USA and also from the World Health Organization. Next slide, please. Women also ask, well, if I've had the vaccine, just like I get the whooping cough vaccine or the flu vaccine, does that protect my baby? So if you're vaccinated whilst you're pregnant, you develop antibodies, and there have now been published cases where the COVID antibodies have been found in babies thought to be transmitted through breast milk, and that might give the baby some protection. At the minute, the data isn't robust enough to say we definitely know whether COVID vaccines are excreted in breast milk or not, but we know that antibodies do cross. There is very little data on breastfeeding, but in theory, there is no reason why it should be a risk. All these vaccines, so any protein that is in there, gets digested by the baby's gut. The enzymes in the baby's gut would digest it before anything could be absorbed. If it is viral protein that is there, if it's mRNA or vector protein that is there. If COVID mRNA vaccine remnants pass into the milk, as I say, they'd be digested. And as the COVID-19 vaccine from AstraZeneca contains a non-replicating virus, that's not going to get across and pose a risk to the baby at all. Next slide, please. In terms of practicalities, where are we? Where are we in terms of the vaccine rollout? So in England, it is very likely that COVID-19 vaccines will be given in hubs and GP practices and not in maternity units. That is the current stance, and they feel that that is how they're likely to continue. So whereas we are very used to giving flu vaccines and whooping cough vaccines in maternity units, they don't think that the maternity units will be asked to give the COVID vaccines, and they'll be kept to the hubs and GP practices. Now, different hubs have got different PGDs, patient group directives for prescribing, and PSDs, which are patient-specific directives. So things are varying slightly from hub to hub, so from region to region. What is absolutely clear is that any pregnant woman that is considering the vaccine needs specific counselling. And we've already talked through the fact that there is that decision-making aid and information leaflet from the colleges that is available, and that should be used. Women have already told us in the survey that the person they most want to have that conversation with is their midwife, so all midwives need to be able to have these conversations. What they are considering nationally, however, is to have vaccine champions available to hubs, specifically to deal with the pregnancy element of things. Now, whether that is somebody physically sitting in the hub or whether it is somebody that is available in a local maternity unit that they can pick up the phone and say, we have got a pregnant woman here, can you have a chat to her on the phone, or what should we tell her? So that's still being worked through the development of vaccine champions in maternity services. Because there are differences between the patient-specific directives for prescribing, one solution to it, because we know there have been pregnant women that have turned up at different places for their vaccines and have been turned away because the people in the hubs haven't been confident or because the prescribing has been difficult. How we've addressed it here at the Women's is that we have got a letter that states that the woman has been counselled, she falls into an at-risk group, and she does have an indication to have the vaccine. She has been fully counselled, she has opted to have it, she has had the decision aid and information leaflet to help her come to that decision, and we sign it, and that can be a midwife or a doctor to say that we have given that information, and they then present it to the hub or to their GP, and that seems to get round the problem of the specific counselling, and certainly in our area the hubs are happy to accept that. The other thing that is happening is there is about to be a national publicity campaign that is going to be launched specifically talking about vaccination in pregnancy, breastfeeding, fertility. They are being videoed at the minute and should be out really quite soon. They were talking about the next couple of weeks for that publicity campaign to be launched. Next slide, please.
Okay, so talking about us healthcare workers, what we know throughout COVID is risk assessment has been absolutely key, and there is no difference in making choices with women for, and for yourselves as well. So risk assess, risk assess, risk assess, and as things change, as more information becomes available, we revisit those risk assessments. Regardless of whether the vaccine is administered or not, hands, face, space and test remain our mantra. So it doesn't mean that you don't have to wear your mask, it doesn't mean that you don't have to be 2 meters apart, and it doesn't mean you don't have to wash your face, wash your hands, but you have to make sure that we continue to be vigilant throughout. Being vaccinated does not mean that employers can then transfer you back to a high risk area when you're pregnant. So if you continue to work and checking the guidance, which is guidance, not legislation, the RCM, the Royal College of Midwives, have actually issued information for pregnant women and also for pregnant employees. So that's where I steer to when we're looking at trust guidance and policy, because it is there to support us and to support pregnant women that we care for. But if you have the vaccine, you then need to make sure that the risk assessment that should be individualised to you is reviewed, not because you've had the vaccine, but because of the position you're in is changing. You cannot be forced or made to go back to a high risk area. So if at 28 weeks it is your choice not to continue to work in a patient facing environment, that doesn't mean that you don't have to go home and shield. You can still choose to be at work, but it's all about risk assessment and your employer working with you to identify where you feel is the safest place for you. But remembering again, the guidance is not legislation. So risk assess is your best friend. It's the only way that we can be certain that we're doing the right thing for you at that time. And again, make that joint decision. So involve your healthcare professional if you're not sure, involve your midwife, involve your employer, and just keep revisiting the guidance at the time, because as we know, it is changeable. And I can't advocate for the RCOG site enough. That's where the Royal College of Physicians are directing their clinicians to, the GPs, everybody's being directed and signposted to the RCOG website, because that is where the latest guidance is in terms of what to follow when we are considering ourselves and also those who work with us. Next slide, please.
So up there is just a list of resources that are available, because this talk, everybody will have their own questions buzzing around their head anyway before this. This talk might have answered some of them, but I'm sure it has brought up lots of other questions in that as well. So up there is a list, and I'm sure the slides will be available afterwards, of where you can find more information, where you can go and have a look and get more information and answer some of the questions that are there. It's really important that you educate yourself. This will only be part of it. We won't have touched on everything that people are asking about, and we'll try and answer all the questions, but there is a wealth of resource out there to have a look. And Rachel mentioned the RCOG website. They've actually got a really good list of frequently asked questions on there. So if you're thinking of something, guaranteed somebody's thought of it before as well. And if you look on there, there are lots of FAQs on there with answers that are quite good. So just to summarise and finish up, the vaccine should be offered to pregnant women aged 16 to 65 who have got a pre-existing condition and they're in an at-risk group. And at the moment that's cohorts 4 and 6 as dictated by the JVCI. That is under review. There's lots of information that will change going forward, and people will continue to have questions. So it's about keeping informed as best we can. I think we can move on to just any questions that people have got. And the last slide, it's a different last slide, don't worry. There was a little quote there about somebody that got the vaccine because they'd weighed up the risks and felt that actually the vaccine was for them the safer option during pregnancy than risking contracting COVID. So I think we can just open up to the questions now. Justin, do you want to comment on that?
Yeah.
In view.
Great. Shall I come back in here, Claire? Is that helpful? Brilliant. So thank you ever so much to Justin, Rachel, and Tracy. Huge amount of information, I think, covered in that session. An even larger number of questions, I think, being put into the chat, which hopefully Claire and Fiona have been trying to sift and maybe group into some key themes. So I don't know whether it's be Claire or Fiona. Do you want to start feeding in some of the questions?
Yeah, certainly. Thank you very much. Many of the questions are very specific to a person's own circumstances, and I hope you understand that the clinicians we have here won't be able to offer individual advice based on the information we have, but there certainly are some definite themes. First of all, a very key one: how long should I wait after the second dose before I try to get pregnant? Is the guidance 3 or 4 months?
So I think the guidance is that you can carry on and try and get pregnant immediately after the vaccine's been finished. So I think there's a lot of misinformation going around on social media. The British Fertility Society are very clear. If you're cleared to go and have IVF treatment, you are also clear to attempt natural conception. So the guidance is very clear on that one. You don't have to wait any period of time after the vaccine. Obviously, if you've got a sore arm, then that may cause problems. Okay.
Thank you. Another question: should I be trying to conceive, should I have the vaccine when I'm trying to conceive? Should I have the vaccine mid-cycle or a week before ovulation? Will that affect the ability to conceive?
So again, if you're invited to have the vaccine and you're of reproductive age, our advice would be to go and have the vaccine, and that comes again from the British Fertility Society. It doesn't matter where you are in your menstrual cycle when you have the vaccine. It makes absolutely zero difference in terms of how the vaccine actually works.
Thank you. Lots and lots of questions about the risk to people, well, to women in particular. So does it very much affect, it depends, doesn't it, on people's roles and their own clinical vulnerability if they're offered the vaccine at the moment?
So is this from healthcare workers?
Yes.
Yeah, so if you are in an at-risk group and you have been called to have a vaccine, then you should get your vaccine. In terms of your clinical role, it's about that risk assessment, and that can't be stressed enough, is that you need to have that risk assessment, and that needs to be an ongoing conversation because things can change, because your risk might be higher if the incidence of COVID is very high in the community that you're working in. Your risk might be lower if the rates drop right down. It depends on the role that you're performing. So it needs to be individualised, and it's about that individual risk assessment that is really important. But if you've been called to have a vaccine, then go and get it. It's not about coercion, it's not a case of you must have it, it's about an individual decision. But if there's any concerns, if anybody that's been asked for a vaccine is concerned about it, there are plenty of resources out there and there are people you can speak to talk that through. We know that vaccine hesitancy is a real thing. And as mentioned in the slide, that is particularly so in the Black, Asian and minority ethnic community. And we don't fully understand it, but that's not just with the COVID vaccine, it's with other vaccines as well, and it's with other things. It's about talking, going through the data that is there, going through the evidence, tell them to talk to their families about it, tell them to talk to their religious leader about it if that helps as well. But it's about that dialogue being there and supporting them to come to the decision. I think Justin wants to come in as well.
Yeah, sorry, Claire, I've just had a rethink about the 3-4 month delay. I think a lot of people are getting a bit confused about the MMR vaccine. So the MMR vaccine is a live attenuated vaccine that we would actually counsel women to not get pregnant for 3 months after having. But that covers mumps, measles and rubella and is different from the COVID-19 vaccine. So as we've heard from all the different slides from from Tracy and from Rachel, it isn't a live vaccine, and so therefore there is no need for you to delay natural conception.
Thank you. That's a great response. Thank you very much. Slightly differently, there were some questions about the effect on male fertility. Does it affect sperm or male fertility?
So I think there is absolutely no evidence of that so far. Now, I think we need, like Tracy actually mentioned something really well during her presentation, and that is, I think having no evidence and having evidence to say that it doesn't impact are two different things. Now, as a researcher, if you're going to design a study to see whether the COVID vaccine has an impact on sperm, you would design a placebo-controlled trial where half of the participants got the COVID vaccine and half of them got a placebo. You would then measure semen parameters before and after that intervention to understand whether there were any problems that the COVID vaccine has on the sperm parameters. No one's going to be able to do that trial because it would be really unethical to withhold vaccine from people, okay, that we know is really beneficial. So what you have to then do is use observational data, and that's exactly what's going on at the moment. Millions of men have now been vaccinated, and there is no reports that the vaccine impacts on male fertility. And I think that's a really important thing to get out there. There is no evidence, and more importantly, no scientific theoretical reason why the vaccines that we're using here in the UK would have an impact on male and female fertility.
Thank you very much. There are some questions about people who have had the first vaccine before they realised they were pregnant, and there's now the question, should they have the second vaccine?
So the advice that's coming out at the minute is if you've had the first dose, go ahead and get the second dose, because actually there is no evidence that this is harmful in pregnancy and women. So there must have been a clinical reason for them to have their vaccine, or they wouldn't have been called yet. Therefore, they should have their second dose. Now, some people are just worried about the first trimester. There is no evidence that it's a problem. They're not teratogenic. There is no evidence to suggest teratogenicity. There is no increased risk of miscarriage that we are aware of, and no theoretical risk why there would be. So what we're saying is have your second vaccine. Now, some people may want to defer it a little bit to get them out of the first trimester. We don't know the efficacy of the vaccine then if the second dose is delayed beyond that 12 weeks. So there is a risk with that. If they decide not to have the second dose at all, they need to be aware that they've not had the full immunisation programme, so we don't know how long their immunity would last. I think Tim's got his hand up to say that he can come in on that. But the advice at the minute is if you've had the first dose to go ahead and get the second dose.
Thanks, Rach. I was just going to mention that I think some of the queries related to people who had the first dose not knowing that they were pregnant, and therefore might not actually be in cohort 4 or 6. So should they continue to have the second dose during pregnancy, or should they wait till after pregnancy?
So that question came up at a different event that I was at. Exactly the same question came up, and the answer that came back from that was yes, go ahead. Now the groups that we'd cover at the minute are health and social care workers, yeah, and women over the age of 50. That happen to be pregnant, because they're the only cohorts that have been called in for it. Yeah. So if you're a pregnant healthcare worker, your risks are still there. So you have got a reason to be vaccinated because of your work-related exposure. So at the minute, the advice is yes, carry on and get your second dose.
Thank you. There were also some questions about should people have Pfizer rather than AstraZeneca? Does the advice vary on having a particular vaccine if you're pregnant?
Tim, do you want to take that one, or will I?
No, I'm happy to pick that up. There is no advice that suggests that one vaccine is preferable to another. So the advice would be if you are offered the vaccine and you are appropriate to have the vaccine, then you should have the vaccine, and you can have either vaccine. there is nothing to choose between the two, and currently you should have both doses of the same vaccine unless there is some extraordinary reason as to why that may not be the case. But generally you have the same vaccine for both doses.
Now, if it changes, if vaccine availability in the UK changes, because there are attenuated live vaccines that are used, or inactivated vaccines that are used in India, I think it is, if one of the live vaccines came to the UK, that one wouldn't be recommended for pregnancy, but the ones that are available at the moment, there is nothing to choose between them.
Thank you. There's also a question, why did the government advice change about giving the vaccine to people who are women who are pregnant?
So,
Tim, do you want to take that?
I mean, I can start. You guys can probably add to it. So, because the vaccines were new, there was very much a precautionary approach taken at the beginning, and because, generally speaking, trials of vaccines, certainly initially, are not carried out in women who are pregnant. The advice was precautionary in terms of giving it in pregnancy and in terms of people getting pregnant shortly after having the vaccine. I think the evidence that became clear pretty quickly was that that caution was not necessary, and the evidence didn't support that. The European Medicines Agency approved vaccines without that precaution in there, and the MHRA changed their advice relatively quickly after that initial precautionary advice to the position that we're currently in.
And I think the other thing to add to that was it became clear really fairly quickly during COVID that the morbidity and mortality in pregnancy was actually high.
Yeah.
So to have an otherwise fairly fit, healthy young woman who happens to be pregnant with a 10% mortality rate, I think that focused the thinking quite a bit. So it was a combination of, we've been a bit overcautious. They were ahead of the curve in the States with vaccinating pregnant women, and the data coming back was fine, but also the evidence that if you get COVID in pregnancy, particularly the second half of pregnancy, the risk of severe morbidity and mortality is high.
Thank you. Lots of people are talking about being concerned about having the vaccine when breastfeeding, but one particular commenter actually said, perhaps it's an advantage if I have the vaccine and breastfeed, then am I passing the antibodies of the vaccine onto the baby?
So yes, there have been some reports published that antibodies have been found in the baby through breastfeeding. So that is a distinct possibility. There, like we said in the talk, there is no evidence that it is harmful to the baby in any way, and we certainly wouldn't want you not to breastfeed. It's a choice. It's like everything else, it is a choice, and we're not here to force anybody to have a vaccine. It's about giving the information. So again, anybody that is breastfeeding, talk to the midwife, have a look at the information that is available, think about it and weigh up the risks and benefits. We know the benefits of breastfeeding. We also know the risks of COVID. So, you know, people get concerned about breastfeeding, but if they had COVID and ended up being separated from their baby for a long time because they were hospitalised or worse, then that impact is much, much worse.
Thank you. And a few people have given instances of going for the vaccine or asking about the vaccine and actually being advised by midwives and GPs and consultants not to go ahead with it. Presumably this is because of specific individual circumstances rather than any general advice.
I think it might just be people being behind the curve, and that's one of the reasons that there's webinars on, and there's been other ones as well. It's about education. It's to make sure that people, because things are changing so quickly, it's about making sure that people are up to date with the information. And like many drugs in pregnancy, there is often, if I'm not absolutely sure, the default is saying, no, you shouldn't have it. And now we know that's not the case. So it's about education and trying to get out there. And if women feel, I've been turned down and I shouldn't have been turned down, again, speak to the midwife. We can give a letter to say we've had the conversation, we've counselled, and we support this woman's choice to have her vaccine.
Thank you. And in fact, there's one particular person saying that a local booking system over in the East Midlands, Swift Queue, as soon as you say you're pregnant, it actually says, oh, well, sorry, we can't take your booking. And I think the advice on that would be perhaps to try the national booking system. The details will follow of that, which will enable you to make an appointment. I think that's probably all the subjects covered. Particularly, as I say, the non-individual questions. It does cover most of the topics that the questions were put forward. Lots of people really seeking more information and more evidence, which we will publish as it becomes live.
Claire, can I just add something? I mean, I was trying to scan the questions as they were coming up. I mean, I think, and I know it was well covered in the talk, but I think maybe it's worth revisiting the question about, and it's a difficult question to respond to in a way, about any potential long-term impacts of the vaccine on fertility. And it's difficult because we clearly don't have 10 years of experience of the vaccine. The vaccine's only been around for less than a year. The trial started less than a year ago, so that's the most evidence that we have about the vaccines at all. So it's a very difficult thing to say we categorically have 10 years of evidence and show there's not a problem. But because the issue of fertility and the vaccines are out there and are in the public domain, albeit probably for not very good reasons, picking up Justin's original comments that this came from somebody's hypothesis for which there has been absolutely no evidence whatsoever. But I mean, it's a bit unfair, Justin, but I just wonder whether you want to try and respond to that query. Because I think there were quite a few along those lines.
I think, Tim, I think you've kind of addressed that really well. But what I would say is, yeah, there's not going to be any trial evidence that we're going to be able to do. Imagine doing a trial where you have 500 women getting the COVID vaccine and 500 women not, and seeing how it impacts their fertility. It would never get through any kind of ethics review board. So the issue for us here is there is a lot of observational data that we can look at the women that have already had their vaccinations. Are there reports that their periods have stopped, that they're struggling to get pregnant? And there aren't so far. And actually the vaccination has been rolled out for quite a long period of time now. And I guess that as a fertility specialist, what I'd say is I sometimes wish that people were a bit more mindful about other elements that might affect their fertility. So, for instance, ages at which they might try and get pregnant, or whether they're using barrier contraception to stop them getting chlamydia, or smoking, or alcohol. Whereas actually, I think these theories that have come over from Germany about whether there is a spike protein has really caused quite a lot of a furore, when actually there is no evidence or scientific theory behind it, really. So I would say we aren't ever going to get that evidence. I've personally seen what happens when people get COVID, and it can do a significant amount of damage. And of course you want to protect your future, but I would say that there's a short, middle and long term here. And I think that protecting yourself from getting COVID, especially if you're an at-risk person, when you get invited, it makes quite a lot of sense.
Thanks, Justin.
Thank you.
Claire, any other questions, themes you want to pick up?
No, I think we really have covered all of the ones that have, all the subjects that have come through. Thank you.
Okay.
Thank you.
So in terms of turning the questions and answers into a document, is that something we're going to pick up? How do we make that available to people?
Fiona has put in the chat that we will make them available on the Birmingham Women's and Children's web pages. That's right, isn't it, Fiona?
Yeah, we in Birmingham and Solihull we have a centralised COVID vaccine programme website, which is Birmingham and Solihull COVID vaccine.nhs.uk. That is accessible to anybody regardless of which system you work in or you know, a part of, and you can access those. So we have a hell of a lot of resources on there, videos, FAQs. A lot of what has been covered in today's presentations is on there as well, and links to the Royal College's documents and evidence as well. So I think we will more than happily put these presentations and videos on there so that people can access them. If you're in Birmingham and Solihull, my team will be sharing these out through your internal comms channels at your health and social care providers, or whichever organisation you are, and I'm sure Claire will share across the entire of the Midlands patch through our regional communications channels, so that those people who are in perhaps other areas such as Shropshire or Leicester or wherever you may be from can make those available to you as well. So give us a day or two to turn them around into useful documents for you, but we will do our very best to share them as far as possible.
Great, thank you. I mean, it might take a few days, I guess, to share the Q&A stuff into a document, because we'll want to make that as tight and as accurate as possible. So that might just take a few days. So good. In that case, I think that probably just leaves me to say a very, very big thank you to our three colleagues from Birmingham Women's and Children's, to Justin Chu, Rachel Carter and to Tracy Johnston. Thank you very much indeed for your time and for your input. Thank you to everybody who found the time to phone in, or to call in, and to ask questions. I hope we've managed to allay some of your concerns and to give you some more information on which to make your decisions. As Fiona says, we'll make as much of this information publicly available on the web as we possibly can. And I wish you all a very safe and secure future. So thank you very much indeed, everybody.